how do you get involved? Each site has, fortunately, in addition to the physician who's the clinical coordinator, they have a study coordinator who is really the person who gets the study done. You approach a potential patient by having the investigator and the study coordinator speak to the family, usually while they're in an outpatient setting. And what we like to do is we give them the brochure about the trial, which is on the website for all of you to download. And we encourage that they read it and come back at a later date, not in the clinic setting, but meet privately with us. We're fortunate enough to have an office away from the hospital where they can sit down in a conference room, and we usually bring 2 or 3 families at one time and talk about the trial. We serve them some goodies, and we informally answer their questions in a very informal manner that takes away the pressure from being in a noisy clinic or hospital setting. And they've had some time to look at the protocol at least and the trial information. And sometimes they'll bring the child with them, but they may want to come without a small infant or child. And we want to advise them in advance that compliance is essential for the study. This cannot be done half-heartedly, as you know. This is the type of thing where they can't miss appointments, they can't miss medications. They have to really pay attention to compliance. If they don't, then the value of their contribution to the trial is significantly lessened. Blood work is drawn at every visit to ensure the patient's safety and determine the dose titrations. And when we looked at the number of times we draw blood, it's not that many more than you would normally do caring for your patients as you put them on a new agent. And after the screening visit and week 0, that's where the medication is dispensed, the visits become further apart and more towards a normal situation. We try and develop a good relationship with the patient. It's critically important, and the family, and they must be able to communicate to us easily if there's side effects or problems, really at a minute-by-minute basis, whether this involves calling the hospital operator, calling the office, calling the page. We encourage continual communication. We want to make sure that the patient and the family are part of this trial, means that they are getting good treatment, the best treatment for the patient, and the best efforts to maintain safety while we try and learn about the best treatment for their children. Some of the helpful hints are appointment reminders. Luz will call the families well in advance to tell them you've got an appointment coming up. Also, we provide pill organizers to help them dispense the medications and let us know when they may be getting low. In the younger child, we use Emla cream for the patients who are hard blood sticks. We want them to be patient. We're very courteous with them, and we're available at any point in time for their needs. So that was what Luz was going to say. She's much prettier than I am, and she gets her message across, and without her there would be no success, at least at our core. Thank you. Questions? Yes, sir.
Is there any attention paid to the influence of various diets in the ancillary studies and in this one?
That's a good question. We have not received an application yet with a proposal to look at diets. It's a very good question. Yes?
I wanted to say we were randomized and we started June of last year. September she was in remission. Her doctor said it was the fastest patient she'd ever had placed in remission. Unfortunately, within the last month, she relapsed. They feel that she became sensitive to the cyclosporin. So we've been playing with that. She's down to 0.03 now. So we are close to being put back into remission. But I just want to say how fast, because her doctor would never put her on the dose of cyclosporin that the study had suggested.
That's very encouraging to hear that. I mean, we've seen patients on the other arm as well go into a remission. So this is good, and she's doing well. It sounds like she's doing very well.
She's fine. She'll tell you it's a condition. She's not sick.
Well, that's good. Go ahead. Yes.
You mentioned levamisole.
Levamisole. It's in
Europe.
It's in Europe. It's and Africa. It's an antiparasitic, and South America. It's been shown to be effective in nephrotic syndrome, in frequently relapsing nephrotic syndrome, or patients who are steroid dependent, and it induces a longer remission. but it's not been studied in FSGS. It's been used in steroid-dependent nephrotic syndrome and some patients with steroid resistant, but no controlled trial ever of that agent in FSGS. It's not approved. It's an FDA. It's not been studied. It's not approved. You'd have to go to another country and sneak it back in.
I have an 8-year-old that was randomized into the study in April.
Okay.
And my question is, you know, at the inception of the study, you wanted 500 patients.
Right.
Now you're down to 200 patients. And you have 54 that are randomized, so that's a small percentage still. Especially if you look at it, 54 out of the total of 500 patients you wanted. What, since it's a relatively low number, how confident can you be in the validity of the results of the study?
Right. Well, it's a very good question because the 500 were based on a statistical conclusion that this is what we needed, a power.
Still a small randomized number, I guess. You know.
Well, what we've learned are a couple of things, and we have a fine statistical group out of Cleveland Clinic being led by Tom Green, who has showed us that if we go to 200, we will still have statistical power in the study of over almost 15%. And even if the 500, it wasn't that much different, you think that 500 makes you have a 50% statistical power? You don't. You're down somewhere around 10 to 15% is what we're looking at from a statistical analysis of that population. And I must admit, I think we were hoping we would get more patients early on into the study for a number of reasons, some of which we're not entirely clear why we haven't had better enrollment. But we've reached out. We're continuing to advertise this trial. Dr. Briggs and Dr. Marva Moxie-Mims are constantly advertising the trial at meetings from the NIH standpoint. And it is an important trial. It's essential. The government, the NIH, has given us an opportunity with funding, taxpayers' money, to do a scientific clinical trial of this condition and obtain samples and data for subsequent analysis, which can lead to newer things. So we're still encouraged that we're going to continue the trial and reach our goal of 200. Initially, and when was your child randomized?
Well, she was diagnosed she had her biopsy in February.
Okay.
And immediately upon diagnosis, they started, talking to us about the trial and sent her slides
Right.
for review.
Mm-hmm.
So that was March-ish, early March, and
Okay.
she was not randomized until April.
Okay.
But, you have to remember, they tell you, here your kid has a condition that there's no cure for, and 50% of the people are going to go to end-stage renal disease in 5 to 10 years. I mean, you feel like, I got to get on that treadmill at 100% and let's get moving. And with the trial, I felt like we could have started into treatment sooner if we had not, waited for that randomization.
Right. Well, I understand.
And we get a glitch that, they collected her samples and then they had to recollect the samples, which, working in a lab, I understand that, but I think that the general population, I think you're probably losing applicants because of that process.
Right. Well, we're aware of that, and we're trying to remediate any delay in treatment.
I'm not trying to get on you.
No, really. I think we need to hear this from the families, and we're trying to expedite it. But to have a scientific trial, like I said, I was much better in the lab working with rats. And then when I had to do people in a scientific manner, it's far more difficult, and the variations are enormous. The urine, one day may be there, come back for the subsequent visit, and the urine protein excretion is within a normal range. So there are a lot of things that fit in, and the lab samples. These samples are done at a central lab, just like the pathologist at your site that made the diagnosis may not be the core pathologist. That tissue had to be sent, those slides, to be reviewed by the core pathologist. So the standards that we need to make it scientifically valuable require time. But I see what you're saying. Most of the patients can be put on some temporizing therapy till they're randomized. And that's what we do. If a patient comes in, and we're considering them for the trial after they've failed steroids, there's no reason why you can't start some of the medications that are in the trial, such as an angiotensin-converting enzyme inhibitor or an angiotensin receptor blocker. We have had children and adolescents that we've put on Cytoxan and given them a 3-month trial of oral Cytoxan with some prednisone, with an ACE or an ARB, and if they have failed that therapy, now you're into 4 to 5 months after diagnosis, they would be eligible for the trial. So there are things to do that are acceptable therapies if we had to. But I understand your concerns. Anything else? Everyone getting hungry? One? Okay.
What if the ACE inhibitor or lisinopril is not proving to decrease the blood pressure, but is proving to decrease the protein reactivation?
Right. Well, this again, the use of the ACE or the angiotensin receptor blocker here is based on prior work. It's common to both arms, so we're not going to really be able to dissect out from this trial any efficacy of those agents.
Well, could something else be added, I guess is my question. Or to decrease the blood pressure?
Well, if they're on an ACE or an ARB and it's titrated to the maximum dose and they're still hypertensive, they can have upwards to almost 3 more agents added. That does not keep them out of trial. They can have any number of drugs of choice of the investigator to put them on. No one should have hypertension. There shouldn't be one patient in this trial with uncontrolled hypertension. And we will, I know there are patients on 2 or 3 medications if they need it. Blood pressure is critically important in all things.
How are the pediatric nephrologists informed that the trial was out there?
Okay, so that involved a large PR process using several organizations. We have an American Society of Pediatric Nephrology, which every pediatric nephrologist in North America is basically part of, and they get constant emails, web information, newsletters, and any meeting they go to, it's advertised. We've advertised it at any of the many NIH-sponsored meetings. It's been advertised as availability of a trial. We partnered early on with NephCure from the get-go to promote this trial, and they still are clearly promoting the trial. We've partnered with other organizations like National Kidney Foundation, and Kidney and Urology Foundation of America sponsored a whole workshop on this as well. Just in May, I was in Chicago for the spring clinical meetings of the NKF, and our colleagues in internal medicine, John Middleton from UNC, gave an hour talk to about 75 internal medicine nephrologists about the trial. So it's constant bombardment. And if I had Tony Soprano as a neighbor, I'd ask him to go door to door. Thank you.